So much. Next, it's my pleasure to invite Dr. Rajesh FOGLA sir, who's been kind enough to consent to be a part of this course for the past few years. And each year we learn something so beautiful and something very practical from our management point of view. And he's our go-to person if anything goes wrong in the cornea. We make a phone call, and he's been very kind to help us out. So, thank you so much, sir, for once again being a part of the course.
Thank you, Shail, for the kind introduction and making me part of your course. And it's always a pleasure to participate. And today, usually I speak about endothelial problems and cataract surgery. So this time the topic was changed, and Shail said, "Okay, I got bored of listening about endothelial keratoplasty. Let's see what you do when you deal with a corneal opacity and a cataract." So. Yeah. So I'll be giving an overview on how to manage this scenario. I don't have any financial interest to disclose. Now, cataract surgery definitely poses a challenge when there is a corneal opacity. And in this scenario, I think there's the importance of advanced imaging techniques. You have to modify your surgical technique and the post-op management. And you have to try and optimize the visual outcome despite the patient having a corneal pathology. So basically, it's trying to bypass any corneal surgery and still address the issue of dealing with the cataract and trying to improve the patient's visual acuity. Compared to cataract, which account for 51% of global blindness, corneal opacity is much lower, only about 5%. The challenges when you have a corneal opacity are the poor visualization, the induced high astigmatism, and sometimes there can be increased risk of complication because the visual acuity is not good. So why do you get the corneal opacity? Commonly we see post-corneal infections or trauma. Rarely in older patients, they will come with degeneration. Most commonly, you'll see the spheroidal degeneration that happens. And in people who are from the Middle East or the equatorial belt, the chronic trachoma also induces a kind of haze. And patients, usually, they stay on till they develop advanced cataract, so they don't come back. And then when you go and look at it, you find that, yes, it's difficult. Rarely we see with stromal dystrophies as well, like granular dystrophy or macular or lattice dystrophy, where when there are clear spaces, patients still can manage, but later on when they develop cataract, and to do a cataract through that corneal dystrophy is sometimes a bit challenging. And also if you have had post-refractive surgery complication like a haze, or if you have done a DALC and there is a corneal haze, then also addressing the cataract can be a problem. So examine the patient on slit lamp, look at the depth of and the density of the opacity. And for me, I think the location of opacity is important. We do a topography and find out if your cornea is regular or irregular. Because if the cornea is highly irregular, you will have problem with calculating the lens power that you're going to put. But having said that, sometimes we see patients who have been wearing contact lenses before when they had an irregular cornea, and they just develop a cataract. So there is no need the patient can undergo a cataract surgery, and you can still go back and wear a rigid contact lens and still maintain good vision. Anterior segment OCT is good because you can see in cross-section how deep the opacity goes, and to evaluate the endothelial health, if possible, we do a specular microscopy. Otherwise, we use pachymetry as a indirect way of telling us whether the endothelium is working good or not, because if your corneal thickness is beyond 600, you know that the endothelium may not be working very good. And the other thing is, even in these kind of cases, you need to have some idea about what's the visual potential in that eye, because your patient is coming back. So these devices like the potential acuity meter, where you project a very small image into the retina, you have into the posterior part of the eye. You can get some readings and you can determine what's the visual potential. Because if the patient's eye is amblyopic or not, patient did not have great vision, then there's no point going through the entire exercise. And depending on the astigmatism, regular or irregular, you can think about whether you want to put a toric IOL or not. Usually, in most of the cases, we prefer monofocal IOL. In complex cases, sometimes you may have to fix a scleral fixated IOL when, besides the opacity, if the integrity of the capsule is compromised, or when you remove the cataract, if the support is not adequate, you can put a scleral fixated, or if the iris is adequate, you can even think about a retro iris fixation of the IOL. And you can also do it as a two-stage. That means the first stage, you just remove the cataract, evaluate the eye, do a proper IOL power calculation, and then come back and do a secondary IOL at a later date. So what do you do surgically? I have some videos, but for some reason, I think there is a glitch in the computer, so the videos are not integrating with the presentation. So we use trypan blue for enhanced visualization during capsulorhexis. You also put, viscoelastic on the corneal surface like methyl cellulose, that also enhances. There have been situations where I have even put a soft contact lens or RGP lens. I put viscoelastic and then I put the contact lens on the surface, and even through that corneal haze, suddenly I find that my visualization is better because the front surface becomes very smooth. And having good retroillumination is also great. You can use even chandelier or light pipe illumination. So having that, like a forced red glow, you can call it when you put a chandelier. Or if you use a light pipe, you switch off the microscope light and use the tangential light to try and get that. So chandelier, for people who are not aware, is a fiber optic source. So it's like when your retinal surgeon is doing the surgery, he's having a light pipe in one hand and the vitrectomy cutter in the other hand, and the infusion is coming. So that helps them see. But if you want both your hands to be free to do membrane peeling or dissection, something, so you can fix the light just like you fix your infusion cannula. You can fix in a light there and then continue with the surgery. So same thing can be done with the cataract surgery as well. If you have blast injury, a lot of foreign bodies on the cornea and those kind of scenarios where a direct visualization is difficult, if you put a retroillumination with the chandelier, you will find that the red glow that you get enhanced makes it very easy for you to do the surgery. Just imagine that if you do your routine cataract surgery and you did not have a red glow, how difficult the surgery would be. But the moment you have a red glow, your confidence increases. You can see the capsule, you can see the fragments very well. So I think this is where you do need a little bit of these devices when you do the surgery. Often you will have poor dilatation, especially because of some synechia. So you need to have devices. Either you can put a Malyugin ring, or commonly we use the hooks. I would recommend that whenever you embark on doing this surgery, have both the iris hooks and the capsular hooks. Because there are times where not only do you stretch the iris, but if you want to support the capsule because there is some, zonular loss or something, then putting in the capsular hook is also great. And be prepared for capsular tension ring, the segments, because whenever you go in a complicated scenario, you cannot evaluate pre-op, then these things can happen. And on table, suddenly you realize that, I don't have it. Then it can compromise the outcome of the surgery. What do you do different in phaco? You go slow, just like you go with compromise. And you take into account that there is a corneal scar, so there must be some problem with the endothelium as well. So use low flow techniques, go slow. I would say that in most of these cases, I don't do them under topical. I would give them a peribulbar block and then do the surgery so that the patient is more comfortable and surgeon is also more comfortable. Use a soft shell technique where you put in a dispersive and then a cohesive. Try to use a chopping technique. So you try to minimize the amount of phaco power that you use and use viscoelastic liberally. Don't try to put your phaco probe in and try to finish the entire surgery at one go and come out. So take your time, you can go back. And for cortical removal, you need to have access from different quadrants. So using a bimanual is always a great option in this rather than going with a coaxial, because that does not give you better access and the control is also not too great. And rarely, if you feel a phaco is not possible, don't persist with it. Sometimes doing ECC or an MICS is equally good, especially if you are dealing with a hard cataract. And visualization is not good. It's better not to lose the cataract in the vitreous, because if you lose and the corneal visualization is not great, it creates a challenge for the retinal surgeon also. And then you have to put in a temporary K-Pro and then you have to do a corneal surgery as well. So a triple procedure, or when do you do a combined corneal surgery? When the opacity is very dense or already the endothelial function is compromised, then I think it's better that you go ahead, combine the surgery. There have been instances where if the cataract is early and not too dense, you can do the corneal surgery first, wait for the the readings to stabilize, and then do the cataract surgery at a later date. Post-operatively, definitely you will need steroids to control inflammation, because the inflammation is slightly more than in other cases. You may need to use sodium chloride, because if you have any corneal edema and if there is any residual astigmatism, patients may still have to wear RGP contact lenses. You can also go back and do topo-guided PRK at a later date for any residual refractive error to smoothen the surface. And as I mentioned earlier, that you can either do secondary IOL, or sometimes you can go back and do piggyback. You can always put a sulcoflex and try to correct. Or people have even are recommending you can put even a toric ICL for any residual astigmatism or anything if it is significant and if you have had an error in the, rather than going back and trying to exchange the IOL, which may sometimes be difficult. Outcomes, it depends on the severity of the opacity and the surgical technique. If it's a mild opacity, most patients can still see 20/40 or better. So I think in conclusion, I think the pre-op investigations, imaging and planning the outcome is important. Don't put it in your routine list and try to do that. See the case, examine, plan, discuss with the patient the surgical complications that can happen and the need for a subsequent procedure. Intra-op visualization techniques, so acquire the light pipe or the chandelier illumination, and I think individualized treatments will definitely give you good outcome. Because if your patient has been seeing well despite the corneal opacity before he developed the cataract, then the goal is to restore the vision back to the same level. So this is in short an overview about dealing with corneal opacity and cataract. Thank you for your patient hearing.
Thank you so much, sir. So I had a couple of questions.
Yes.
One is patients who have had this corneal opacity due to, say, recurrent viral keratitis.
Yes.
So it's been, if the eye has been quiet for a year and a half, they are not on any antivirals or so. But before planning cataract surgery, would you restart them? Or
we will restart, because what happens is when you do the surgery, the surgical stress and the use of topical steroids in the post-op increases the risk of a recurrence of the viral keratitis. So I would at least maybe 1 to 3 months before, I will start them on oral prophylaxis and then continue with that. And if anybody has difficulty in taking oral prophylaxis, topical ganciclovir ointment is available with us. So we can start that thrice a day, and that also gives some amount of protection preventing that. You can even add it in your post-op regime and continue with that till the time the patient is on steroid.
Okay. And sir, quite often we have some of these patients with corneal opacities have some adherent leukomas in the mid-periphery to periphery. So if the rest of the pupil is dilating and if you are able to go ahead with cataract surgery, would you still recommend removing that adherent leukoma for the cornea? Or
again, it's again depends on the extent of the adherence. If it's just a focal adherence or something, since you are going inside the eye, you can always go with the scissors and snip it off. But if it's a broad adhesion, where by trying to remove it you will induce more pigment release, inflammation, then I don't see, as long as it does not interfere with your surgery and you can do your surgery well, I think you can just leave it, because you don't want a new problem to happen. Because when you release that, and if the iris is, you don't have a pupil, sometimes the synechiae will recur and they may be worse than what you started with.
off with. Thank you, sir. Thank you.